a le plaisir d'accueillir le professeur Vincent RIGALLEAU, qui est professeur et nutritionniste au CHU de Bordeaux et qui fait partie de l'équipe nutrition, épidémiologie de la nutrition du centre INSERM 897. Là, je vous le dis en français, mais il va vous faire une présentation en anglais.
Well, thank you for your invitation. It's really a pleasure to talk about this nice topic in English, diabetes in adults. I have conflict of interest, but they are not very interesting. Only this one with the Turkey, but let's go on. So, we are now facing more and more obesity. The obesity study shows that French people, French adult people, take about 1 kilo every 4 years, and you can see along the years our body weight that is increasing. And with more and more obesity, we are more and more diabetic. And among the years, the prevalence of diabetes increased, especially in the overweight of us, and especially in the obese people, because obesity predisposes to diabetes. So we now see more and more diabetes in France, and the Untitled study shows the increasing prevalence of diabetes from here 2.7% about 15 years ago, and now 4.4%. And 4.4 is not very much, but we must see that in the seniors, after 65 years old, that's more than 14%. And these patients are not only doing diet and physical activity the best they can. They are also treated with many drugs, and almost 20% must use insulin to treat their diabetes. I want to give a little hope, because this is a recent result this month of the Framingham Heart study. It's a well-known cohort, the Framingham cohort. And in the Framingham cohort, there is a similar trend. With decades, you can see the growing BMI of women and of men also, and the increasing incidence of diabetes. That is the conclusion of this recent paper. Maybe there is a plateau. We shall see in the next years whether this is true. Let's hope. Sometimes good news can also be seen. You know that there are two kinds of diabetes. This has been said, and sometimes there have been questions about the diagnosis of both types. In fact, it's clinical. In almost 90% of cases, you can perform the diagnosis only by discussing with the patient, and it takes about 2 minutes to make the distinction. Most of diabetics have type 2 diabetes. This usually begins after you are 14 years old. Of course, there are exceptions. Now, there are some cases in children, but in most cases, it's a maturity disease. Most of cases are diagnosed by screening without any clinical things, because general practitioners are good. They know it's the good way to go into the disease. The general practitioner find that you are a little overweight, or even obese, or you have cardiovascular risk factor, or you have a family history, and they ask for you to perform a blood glucose control, and they find it. In in France, in Aquitaine, in a little number of cases, a little less than 10%, the diagnosis is performed by a specialist. And it's not a diabetologist, it's a cardiologist or a neurologist who finds your diabetes because he sees you doing a myocardial infarction or a stroke. It's a bad way to begin with the disease, but it's possible. It's a hereditary disease. Each of first-degree relative has a 20% risk of having diabetes when you have diabetes. So you have a mother or father, and you have a brother or a sister in many cases. So 2020, in most cases, in the majority of cases, there is one diabetic in your family if it's type 2 diabetes. It's quite different from type 1, which is also an hereditary disease, but it's 3 to 5% on a positive relative, much less. There is, of course, a body weight history which is very different, with overweight on the higher part of the body, and underweight, overweight, and high waist. And there are other symptoms of insulin resistance that are parts of the metabolic syndrome, hypertension, and dyslipidemia. For each of these characteristics, type 2 diabetes is different from type 1 diabetes, and then the differential diagnosis is not difficult in most cases of both. There is a little minority where you can discuss. You can even have both diseases. And when it's difficult, you can also think for some rare for diabetes. There are about 15 forms, 15 kinds of diabetes, moody, secondary diabetes, etc. What is diabetes? It has a definition. The World Health Organization has said that it's chronic hyperglycemia. We have a threshold, 7 millimoles, it's easy, with risk of vascular complications. And there are two types of complications. The microangiopathic one, which are specific, retinopathy, nephropathy, neuropathy. It's a disease of the little vessels, of the capillaries, and it affects terribly your quality of life, because it hurts, because you have ulcers, because you may become blind. And macroangiopathy is not specific. You can have a stroke or a myocardial infarction without being diabetic. And other factors play great roles, like hypertension, tobacco, or dyslipidemia. But this affects more the diabetic people, and it affects very much their life expectancy, which is reduced, as we have seen this morning. So it's coronary, cerebral, and peripheral arterial disease. For diabetes, we have treatments for both types of diabetes. For type 1 diabetes, insulin, of course, is there, and we know that good glucose control reduces the complication about by half. That's the DCCT trial, the most important trial for type 1 diabetes, and the reduction of the number of retinopathy was about, half reduction at the end of the DCCT, and this was confirmed later, 4 years later, when the study was pronounced. For type 2 diabetes, here, this comes from Stino. For type 2 diabetes, we know that blood glucose control is good, but multifactorial intervention, and this was very fantastically demonstrated by the Stino team, multifactorial intervention with lower hemoglobin A1C, but also lower lipids and lower blood pressure, and a good diet also, is able to reduce the number of microangiopathic complications, and also of later, 5 years later, you can see less cardiovascular events and less mortality. So we have strategies to reduce the complication of diabetes. Of course, they are not perfect. It's only a half reduction, and we may there is a place to do better. So when you know that, what is diabetology? And my daily work is to perform this in a diabetology unit in the Bordeaux hospital. First, you make a diagnosis. Is it type 1? Is it type 2? Is she pregnant? Is it gestational? Maybe type 1 or type 2 during pregnancy? Is it something else? It's indispensable for medicine to begin with the diagnosis. Second, we initiate a treatment. Always there is diet and education. You cannot do without it. And it is, for some patients, oral drugs or insulin. It depends on the case. Type 1 insulin and oral drugs for type 2, but this can be discussed in some cases. And then you follow up. It's chronic disease, the patients. When you follow up, you want good glucose control with HbA1c about 7%, but you want also to prevent the hypoglycemia, which are due to the treatment only. Diabetes does not give hypoglycemia. And you have to follow up blood pressure and lipids. And then you screen for complication. Because when big complication occurs, only a few are treated by diabetology themselves, like diabetic food. Most of complications are treated by cardiologists, or attention, or neurologists, etc. Retinopathy, neuropathy, macroangiopathy, you screen because it's always better to find a complication before the clinical symptoms. You better treat them. Here there is a red star for nephropathy because this is a special complication that accelerates all the other complications. It's well known. When you do this, what you see? First, in a diabetology like ours in Bordeaux, this is a little paper that we published a few years ago about inaugural diabetes. Diabetes that goes already to the hospital at the first symptoms because it is spectacular, because there are many things in these patients. And the diabetology unit is useful for this patient. And we have studied this patient when our work was open 15 years ago. For 2 years, there were 61 patients, and now, 3 years ago, 12 years later, there were more patients. That's the epidemic. Second thing that may surprise when we found that they are getting younger. That's very, and that's true. I see patients that are getting younger in a population that's getting older. And my colleagues who perform pediatrics say the same thing. They are getting diabetic more earlier. Very young babies now can become diabetes. And that's true, they are younger. I am older, my patients are younger. And you can see another thing, it's not significant, but almost. They are bad informed, and they see publicities, and they drink sweetened beverage. And they have a disease that gives you thirst. And this plays a role in this presentation with very high blood glucose level at onset. It should be a chronic disease because there is only about 1/3 of these patients who have type 1. Many type 2 in these patients here. And last thing, it's not significant also, but there is significance in some subgroups. They are heavier. They are taking weight. You can see this also in our patient. And soon, the next thing you can see is injustice. Injustice is for all patients who have complications. But here, in this patient, about 10% will have retinopathy at onset. This means that, in fact, their diabetes is ancient, is an old disease that nobody has seen. These patients are mainly type 2 patients. That's the big problem, because type 1 diabetes usually has no kid symptoms. You cannot ignore it. It's actually very rare cases. And there are also other injustices you can see. This comes from the DCCT, and I have told you that the DCCT has shown that you have a lower rate of complication when you treat well your type 1 diabetes and you reduce the plasma glucose. But there are exceptions, and not so rare, with early worsening in the intensive group or retinopathy. On the long-term basis, it's always better to have a good glucose control. But this is especially catastrophic for the patient, because these are patients who, I see such cases, who do their best, who obtain very good blood glucose control, and may become blind. What happens to this patient? This raises the question of the metabolic memory. The metabolic memory is the fact that maybe the risk of complication is not only from your blood glucose at the present time, but from your blood glucose a few years ago. Here, this has been proven in the DCCT with the relationship between the HbA1c level and the risk of retinopathy. And the strongest relation is not with the present retinopathy, but 2-3 years ago. It's a stronger relation. That's a symptom of metabolic memory. Metabolic memory is probably due to the accumulation of advanced glycation end products, because there are mechanisms between high glucose level and later vascular complication. These mechanisms have been shown very nicely by this researcher, Bromley, who is diabetic himself, and who has detailed this in, I think it's a Nature or Science, Nature, I think, with the polyol pathway, the exosaline pathway, the protein kinase C, and mainly coming from the blood glucose, the accumulation, the deposit of advanced glycation end products. And this is one of the main mechanisms for diabetic complication. When glucose is combined with lipids or protein, this produces chemical species that are toxic for some cells and for the vessels. Here, in the DCCT, you can see that 200 type 1 patients from the DCCT had a skin biopsy at the end of the trial. And there were the concentration of advanced glycation products, furosemide, patozidine, carboxymethylisine, were measured in the scan biopsies. In the intensive arm of the DCCT, the ones who were the best treated, there were less advanced glycation end products and less complication. But we cannot perform skin biopsy to all our patients. It's an invasive. In a diabetic who has eating problems, it's an invasive procedure. So we are quite interested in this apparatus. This is called an age reader. It's a small device, in fact, and here you can see, you put your hand and here is your forearm. It illuminates the skin and it takes advantage of an interesting property of advanced glycation end products. They are fluorescent. And because of that, not all, a great part of them are fluorescent. And because of that, the reflected light can be measured, and skin autofluorescence can be measured, and skin autofluorescence is in fact correlated in this paper from 10 years ago from a Netherlands group, is correlated, skin autofluorescence is correlated with concentrations of advanced glycation end products. This technique has a lot of interest for us. As you can see here, this is the result of skin autofluorescence from a series of healthy subjects who were studied in the Netherlands. And you can see with age the growing of skin autofluorescence, and it's logical because advanced glycation end products accumulate in the body with age, and they may play a role in the aging process. So we have a scheme to study this phenomenon. Accumulation of age can be easily and non-invasively measured in our patients or in some other populations. They may accumulate from androgen metabolism if there is hyperglycemia, or maybe from nutrition, because there are advanced glycation end products when our food is too much eaten. Age plays a role. Genetics surely play a role in the accumulation of advanced glycation end products. Here, Pascal Barra, who is a pediatrician, has shown that skin autofluorescence is correlated between the young diabetic patient he follows with his brother, who is not diabetic. Of course, renal clearance plays a role because the AGEs and their precursors are cleared by renal and in part by the hepatic way. And when it accumulates, it provides lesions. The lesions you can see in a diabetic complication in the vessel, big vessel, in the eye, the kidney, the nerve. But maybe also in unexpected sites, as the brain, maybe this plays a role in their cognitive decline, in the placenta or in the newborn. Maybe this plays a role in the complication of gestational diabetes. And maybe it may accumulate also in the pancreas or in the muscles or in the liver and play also a role in the metabolic disturbance of diabetes. Well, we have a lot of hypotheses and we have projects to study this. We study this here in the elderly subject of the ADENO study, and in the type 1, type 2 diabetic patient we follow in Bordeaux Hospital, and in the pregnant woman with gestational diabetes we follow. And there is also project in young babies that are performed by Thierry Lanero, who is a pediatrician from our group in Bordeaux. I shall show you some examples of these studies that we are now performing. First, one simple type 1 diabetic subjects in our world, and we measure skin autofluorescence. It's higher when they have nephropathy. It's higher when they have retinopathy. As you can see, the differences are significant, but this cannot be used today for a diagnosis because there is a large overlap between the groups. In these patients, interestingly, we have studied, analyzed the relationship between the skin autofluorescence and the HbA1c. The HbA1c that reflects the glucose control from the 3 last months. Well, there is no significant correlation with the latest HbA1c, but we have patients that we follow for years. We see them every 6 months. And when you calculate the mean of the last 5 HbA1c, a correlation significant appears. And if it's the last 10 HbA1c, the correlation is more significant. This suggests that this is a metabolic memory marker. Another example is that in type 2 diabetic patient we follow here, the correlation with the renal function, inverse correlation, it reduces with a bad renal function. And the third is, I think, the most interesting. This is work performed by Kalina. And it's about the value of skin autofluorescence in the elderly population. Yes, almost finished. Here, the old people from the 3C cohort were included 10 years ago. And after 10 years of follow-up, we have performed measurement of their autofluorescence. So we can see, is there a relation with this autofluorescence with here, their plasma glucose or their diabetic status, and also their renal status. So the result obtained by Kalina are that the autofluorescence significantly increases only when you have long-standing diabetes. It does not reach significant for recent diabetes, and it's the same for chronic kidney disease. And when you perform correlation with the glycemia or the HbA1c, the correlation is significant only with the ancient, the old 10 years ago glycemia or HbA1c, and not with the recent one that was performed simultaneously. So this suggests that this is a marker of metabolic memory. I shall not talk about what we perform in pregnant women. This will be for another day. And I go. So we have more diabetes, more obesity, and there is a role for advanced nutrition and products in their complication. Skin autofluorescence is an interesting way to evaluate their accumulation, and it's so simple, it's so quick, it's so low cost that you can use it for epidemiological studies. Maybe it will help the clinician, the future, and our work. I hope we say. Thank you.